All right. Good morning and welcome everyone. Thank you for coming to join us for our SIDA, Sudanese Infectious Disease Association Grand Round. We're very happy and pleased to have Dr. Khalid Dosa to speak to us today about Mycobacterium abscessus. Please start, Khalid, and introduce yourself to the group. Thank
All
you.
right, thank you so much for having me today. My name is Khalid Dosa. Most of you know me. An assistant professor for adult infectious disease here at Case Western. I trained in this program. I did my residency and fellowship too, and was previously in Qatar, Doha, where I trained too. So many friends in this group, and delighted to be here. Yeah, this presentation actually, I prepared it for an upcoming meeting in March, and I kind of updated with the most recent data that we have. It's gonna take like maybe 50 minutes or more to go over everything that I want to talk about today. Uh, but basically, feel free to stop me anytime if you have any questions or if anything unclear. Don't have anything to disclose with regard to this presentation. So just wanna throw this on the audience here. This is kind of classical case. We sometimes see this is a patient I actually saw. He used the tap water to imprint the tattoo at home, and this is one of the NTM, skin and soft tissue infection, that we commonly see here. It takes a while for like somebody move from different providers until like somebody think about like NTM, and that turns out to be like Mycobacterium chironi. The nontuberculous mycobacteria are ubiquitous in water. So if you took shower in the morning, you probably exposed to some of the nontuberculous mycobacteria. They're available in the environment, in the soil, water, and everywhere. And then when you have a situation like this, we're imprinting the tattoo at home. So that does not seem like a good idea. Okay, so these are the objectives of my talk here. I'm going to go over the presentation step by step. In the introduction section, we're going to go over some basics about the NTMs, and also we'll discuss the Mycobacterium abscessus and how there is like this concept of smooth to rough transition of the colonies that like make the bacteria more virulent and its ability to break the granuloma and cause disease. And then we can over review the current treatment options and also discuss the macrolide resistance. I'm going to stress on that for a few minutes. And then we'll go over the need for alternative therapies, and I will like explain why we're doing all this concept and work regarding the dual beta-lactam treatment. And we'll go over the BLAMAP, which is the beta-lactamase that the Mycobacterium abscessus produce, and the mechanism of action of this BLAMAP, and we go over the evidence supporting its use in NTM, like using the inhibitors to suppress the BLAMAP. We talk about future directions, and also we'll conclude at the end. I have like so many cases embedded within my presentation, so we'll go over it. So this is the first case that I saw when I was a fellow. This was my first clinic ever. So I think that what drove me into this NTM world. Was an 85 years old male. He's had a CLL, or chronic lymphocytic leukemia, treatment experience. He was diagnosed in 2006, has been through multiple lines of chemotherapy, and then relapse and all that. And then finally, he was put on ibrutinib. You guys all know that ibrutinib is a bruton kinase inhibitor that is now, there is an FDA warning regarding invasive fungal infection, but this is something else. That's not a fungal infection. So we it's just coincidence. Ahmed Babikar, who co-authored this paper with me, he saw this patient in Pittsburgh, and this patient ended up like in my clinic. I don't know how, but it was because I was at the BA, and then he came from UPMC. So when I saw him first, there was like these skin lesions. They're all over his body. He was not very sick or septic or anything, but this was skin lesions that are really bad. On most of the diagnostic workup, Ahmed Babikar did it. Actually, I don't see him in the audience here. or maybe he joined. But basically, the Mycobacterium cheiloni was diagnosed using the 16S ribosomal RNA. 'Cause sometimes even with the routine culture technique, they fail to isolate this organism. So Mycobacterium cheiloni was diagnosed based on the 16S ribosomal RNA. The patient was treated with multi-drug regimen, linezolid, doxycycline, clarithromycin, and over the next 4 months, most of his skin lesions were subsided, and it was like really. We published this paper in the Open Forum idea, and this was kind of like the first case of invasive and tuberculous mycobacterium infection in patients receiving ibrutinib. So it was kind of really interesting. The paper is available online if you guys want to take a look at it. So then I'm going to talk a little bit about the mycobacterium cell envelope. So there is no outer membrane with the mycobacteria, unlike gram-negative bacteria where they have an outer membrane. In the gram-positive world, we have this thick peptide glycan layer. The reason why I'm talking about this now, because this is the focus of the research that we are doing now. So this is the peptide glycan layer, which is basically amino acid or like amino acids that are cross-linked by certain enzymes. This peptide glycan layer is really thick in gram-positive bacteria, and there is the teichoic and the lipoteichoic acid decorating this cell wall. Okay, and then unlike gram-positive and mycobacteria, the peptide glycan layer is not that thick compared to this one, so it's less thick, and also there is this thick crazy looking lipid bilayer that covers the peptide glycan layer, which is close to the cytoplasm here, but this is just a crazy looking cell wall in the mycobacteria. So it's completely different from gram-positive, gram-negative. And, I like to just describe it as a melted candle that covers the peptide glycan layer. So the cell wall by itself, it's very complicated in mycobacteria, and the multiple lipid-based molecule has been like really challenging and associated with like a lot of the pathogenicity and the virulence of this microorganism. So just to compare, for the gram-negative, we have the outer membrane. In gram-positive, we have thick peptide glycan layer, and we have the teichoic and lipoteichoic acids here. And in the mycobacteria, we have this lipid bilayer that is like resistant. Okay, so the Mycobacterium abscessus was first described in like 1950 by this Dr. Moore, who with his colleague, who described that does not produce a progressive disease, and also described it as a bacterium of low virulence. Were they wrong? Maybe yes, but there's a lot of now discussion that the Mycobacterium abscessus has gained a lot of virulence factor over time and evolved with time. So it just tells you that these organisms, they do not stay the same. They change with time and become more virulent with time. But I mean, when it was first described, it was like bacterium of low virulence. This was in 1915. So of course you guys all know this, but the mycobacterium that we are referring to here are the non-tuberculous mycobacteria, are these mycobacteria that do not cause tuberculosis or leprosy. They have different names. The atypical mycobacterium other than TB. These are all names. And again, as I said, if you took a shower in the morning, you're probably exposed to one of these NTMs. So they are ubiquitous in water and the environment. They're available in soil, water, lakes, rivers, municipal water system. They are also resistant to chlorine and most disinfectant. And they have like very interesting ability to form the biofilm, which is the most disastrous thing. And you guys know that there's a lot of work on biofilm eradication and all that with certain organisms now. So this is an area of hot research. They live inside the amoeba, Legionella, and others. So this is the classical Lady Windermere. The pulmonologists, they kind of love it because this is the classical host for MAC pulmonary infection. Right, and here, so of course, unfortunately, there's like more than 200 different subspecies, species and subspecies of the tuberculous mycobacteria has been described, and they're responsible for like wide range of disease, ranging from pulmonary infection, cervical lymphadenitis, bone and joint infections, colon soft tissue infection, and also they can sometimes lead to dissemination. So it's just like tuberculosis, and here, in this table, the Mycobacterium abscessus the non-tuberculous mycobacteria are further classified into rapidly growing or slowly growing. And this basically differentiation is based on how fast they will grow in culture. So any organism that grow less than 7 days is considered rapid grower. If it grows more than 7 days, it's called like a slow grower. And among the rapid grower group, we have the Mycobacterium abscessus. I really want to focus on these three subspecies because the treatment outcome is completely different. So we have Mycobacterium abscessus, Mycobacterium abscessus bulleti, and Mycobacterium abscessus mescilens. Okay, so these three subspecies, we're gonna get to this later on in the presentation, but I just wanted to highlight on this now here. And then we have the Mycobacterium cheiloni and Fortitium. These are opportunistic pathogens, and they're isolated when isolated from a specimen. Sometimes they're responsible for disease. Sometimes they might be just contaminating. So the ones in blue are opportunistic. The ones in yellow here are saprophytes, which means that they rarely cause disease and they're most likely contaminating the specimen, especially like from OR or any specimen. So you can just basically you can do like watchful waiting. And these here in green, they're almost pathogens. Mycobacterium marinum, ulcerans, Mycobacterium TB complex, and Mycobacterium legreen. Whenever these are isolated, they are most likely organism causing the disease and causing a true infection, okay? And here the non-tuberculous mycobacteria basically just put in this schematic here based on their ability to cause disease. So Mycobacterium gordoni, whenever isolated from a specimen, it's most likely not a true pathogen and a contaminant. But while here, Mycobacterium tuberculosis, isolation from any specimen, it's 100% pathogenic and causing disease. We have the intercellulare here, and we have abscessus and avium. The reason why I'm talking about this here now, because sometimes when you isolate Mycobacterium abscessus and avium, you can look at the treatment regimen and look at the patient, and you might see the patient like doing very well, and the regimen that you might put him on or the patient on might be worse than the disease itself. So you just like watch and see how the patient will go and all that. But when you have like Mycobacterium tuberculosis or Mycobacterium or MAC intracellulare, these are like mostly like pathogenic and also cancers. Yeah. All right. I'm not gonna spend like too much time in this slide, but just the number of non-tuberculous mycobacteria are growing. This is based on the most recent epidemiological study where they found that the numbers are actually increasing. And for some reason, the area of Florida and the West Coast and Hawaii area and Wisconsin area here, and sometimes like in New York and the East Coast, there is like increasing number of cases. And I don't know if this is related to the proximity to the water or like the weather. It's not clear actually, but there is like a very interesting concept here. Like, warm, it seems like the warm and humid environment is like really risky. I mean, people who works in Florida, there doesn't come like a single day in clinic without seeing mycobacterium, non-tuberculous mycobacteria infection. So this is kind of like really interesting. So here, just to highlight their association with increasing mortality. So you can see here probably the number of non-tuberculous mycobacteria diagnosis is on the rise. And then the characteristic of these patients, they are mostly male. They have higher number of pneumonias, more frequent history of smoking, obesity, COPD. So, a lot of these patients, they come with like bronchiectasis, COPD. They keep like coming to the ER. They treat it as exacerbation until somebody will send a sputum AFB, and then boom, one of the NTMs will show up, and then the treatment will completely change. Also here, this paper in PLOS and the veteran health administration, also the number is increasing. So I'm not gonna spend a lot of time here. And these are all considered like risk factors, which we already know about. Again, the NTM infection, pulmonary infection, was linked to worsening COPD and increasing mortality, even when adjusted for COPD and other covariant. So the survival of these patients is definitely influenced by the NTM infection, whether it's pulmonary or extrapulmonary infection. So there's like urgent need here, like to early diagnosis and intervention. So here I just want to do some exercise for everyone. This is the most common clinical scenarios that you will see. So a patient with contact lens developed NTM keratitis or eye infection. What is the pathogen? Quickly, anybody can participate. Just pick any NTM. All right. Uh, Okay, so it's usually Mycobacterium pylori. Okay, so this is the most common cause of keratitis or lens-associated eye infection. Any NTM that can be associated with hospital infection, there was like report from hospitals when they are like, especially the CT surgeons, when the patient can develop like NTM infection post-surgery, post-cardiac thoracic surgery. It was kind of the water system was kind of contaminated with NTM, and then when they're like washing out and a lot of patients develop complications from infection, which is usually hospital acquired. Any idea? Okay, so
Chimera.
yes, awesome. Thank you. I don't know why I answered before I hear the Ahmed voice. But Mycobacterium chimera was associated with outbreaks, but we've seen also abscesses, fortitium, and Mycobacterium pylori. There's one NTM that has like really predilection to the lines and ICU people and cause line related bloodstream infection. And NTM, which one? Okay, so it's mucogenicum. Okay, I don't know if we have any fellows here with us, but sometimes in the board the review and questions, the Mycobacterium mucogenicum tends to be associated with line-related bloodstream infection, especially in ICU patient. There is certain mycobacteria that can lead to disseminated disease in HIV patients, and these are like the Kansasii, Mycobacterium jejunensis, and Mycobacterium haemophilum, which mycobacteria associated with tropical area, patients coming from tropical area with like NTM infection. This is
Marina.
yes, Marinum and ulcerans. Thank you so much. Yes, so Mycobacterium Marinum and ulcerans. And then what Mycobacteria that's almost always a contaminant. We kind of talked about it, but it's Mycobacterium gordoni. Okay, so interestingly here, I think for us an ID physician, the quantiferin test or the IGRA test sometimes can be false positive, and this is due to like some exposure to NTMs. I don't expect anybody to answer this, but feel free to.
Kansas CI.
Yes, thank you so much. Yes, so we have Mycobacterium kansasii, Mycobacterium marinum, and Mycobacterium zoologii. Okay, so these, if you come in contact with these, so the kansasii is basically mostly in the western part of United States here. Yeah, the Mycobacterium marinum, again, it's a tropical area, and Mycobacterium zoologii is basically an environmental non-tuberculous mycobacteria, and you cannot prove it. I mean, we get sometimes consult like, hey, the patient has no exposure to TB. Is there any possibilities that's one of the NTM actually cross-react with the IGRA? I mean, yes, but how can we prove this? No way. There is one non-tuberculous mycobacteria that can be sometimes, when you drink water, if patient has like aspiration or microaspiration at night, they can develop like aspiration pneumonia, and this can be due to Mycobacterium fortitium. Some physician will just like watch it, some physician will like decide to treat. I don't think it needs to be treated, but like watchful waiting might be a good idea. And what is the NTM that's associated with fish tank granuloma?
Marinum.
Madam, yes, thank you so much. And then we have the hot tub hypersensitivity pneumonitis.
Avium.
Yes, thank you so much, Mycobacterium avium. And then the only non-tuberculous mycobacteria that can be treated similar to tuberculosis is Mycobacterium kansasii. And finally, the breast implant. For some reason, Mycobacterium abscessus has very very like it tends to infect this breast implant. So a lot of time, drainage, explant, but nobody sends AFP, wound not healing, complications until somebody like send an AFP culture. So just make sure whenever you're seeing a whenever you're seeing implant infection, you think about the Mycobacterium abscessus and make sure the AFP culture is sent. All right. Again, there was outbreaks here in the United States that people who goes to like nail salon, they can get like furunculosis. This is Dr. Winthrop. He's behind like most of the clinical cases that published with NTM, but Mycobacterium fortitium, it's a rapid grower, treatment of 4 months, usually guided by susceptibility and sometimes can be self-limiting. I like this paper. It's called Happy Buddha. Again, this is Dr. Winthrop. Basically, a person like imprinted the tattoo and they thought like the tattoo had measles, but in fact, this is just Mycobacterium chelomi was kind of associated with the tattoo and that's it. So it's almost always macrolide susceptible, and you use 1 or 2 agents. So the guidelines recommend between 3 to 6 months for skin and soft tissue infection when you have NTM infection. So I mean, sometimes this can be self-limited, but so a lot of physicians they have tendency to treat it. So it's kind of like very interesting. So let's go a little bit background. How do people like get mycobacterial abscesses? It's difficult to eliminate, and I mentioned that it's associated with the biofilm formation. So you have a biofilm in water. Sometimes they live in the amoeba, fomites, and there's like some concern now there might be some infection from like person to person. Once the person get the infection here, the granuloma will form, and then it's just similar to TB. Okay, so you form a granuloma here, and the TB cell and T cell macrophages will contain the infection, and the adaptive immune system will keep the bacteria under control. And then what happens, this smooth to rough transition here, the colonies will go from like smooth to rough shape. Whenever this happens, the granuloma will break, and then you start developing disease. What determined this smooth to rough transition is still like an area of research and investigation, but generally speaking, this smooth to rough transmission has been thought to be the leading cause of like why patients will have this disease under control and all of a sudden start developing abscesses or like cavities in the lung and all that. So this is very nice paper that was published in 2020 and that discussed this smooth to rough transition. And then the investigator in that study actually went ahead and they did something, which is these are all transporters. These are 3 transporters here where they transport the glycopeptide lipids across the cytoplasm and cytoplasmic membrane. Okay, so when they knocked out, which is they deleted the gene for these transporters, they found that this GLP is no longer transported and the bacteria will stay in the smooth phase. So whenever this glycopeptide lipid is transmitted, the bacteria will go into rough phase. So just kind of explain that drugs that can target these channels here might be like of interest. And just here, this is electron microscopy. Just basically shows that the bacteria was contained here inside the granuloma, as you can see here. And then when it starts like becoming rough, it goes into cord-like structure and then break the granuloma, and then you see the local disease and invasion. So that's kind of interesting. Then not too far into fellowship, after 3 months, this woman just walked into my clinic. She basically 46-year-old, had ovarian cancer, treated with carboplatin and gemcitabine. Basically, she had multiple surgeries. She had like infection in her index finger, multiple surgeries until like plastic surgeons that decided to send the 16S from the surgical specimen because all her cultures were always negative. Even her AFP culture was negative. And then somebody like sent the 16S and she was diagnosed with Mycobacterium chelomi. And then we also published this case in the Open Forum ID, basically just highlighting that immunocompromised patient, she just stuck her like finger with a CR chain. And then after that, she developed this necrotizing infection in her hand. And luckily she was treated and she did fairly well. So, we go back to mycobacterial abscesses here. Like the problem with most of these NTMs is that when you isolate them from respiratory specimen, it's so hard to determine who to treat. I mean, sometimes patients are doing fine. It's just like this BL positive for like NTM. What do I do with it? How long do I treat it? How, what are my established outcome parameters? Which means that, do you have to achieve a microbiological cure or maybe just put the patient on regimen, and the goal will be just to improve symptoms or improve in lung function or just improve quality of life. Doesn't necessarily need to be sputum culture conversion or like culture conversion. Sometimes just put the patient on antibiotic for just to control the infection not getting worse and not actually. So it doesn't mean that when you isolate an NTM, especially for the pathogens that we talked about, that sometimes can be, sometimes cannot, we need to decide whether, like, it's a clinical decision making, and sometimes they call it the remedy is the regime, the remedy is worse than the melody, which means that you put a patient on combination IV, oral, inhaled, will actually, will feel worse, and because of the intolerance of drug side effect interactions, patient sometimes cannot afford this lengthy calls, complicated medication regimen. And then the question is, there's a big debate whether the media that we use now to test the susceptibility results of non-tuberculous mycobacteria is the right media, because sometimes in vitro susceptibility does not usually translate into clinical outcome or clinical improvement. So this is like an area that I don't want to go to in my talk now, but we will. But I'll be happy, like, if we want to go for another session. So here I'm going to spend some time in this slide because it's particularly important information here. So with the Mycobacterium abscessus, we have three subspecies: the abscessus, Bolettii, and mescellans. Okay, if you want to get one Mycobacterium, if you are to be infected by Mycobacterium abscessus, you choose this one, Mycobacterium abscessus mescellans, okay, because it has an gene that is unactivated. The most important drug for management of Mycobacterium abscessus is the clarithromycin. You lose the clarithromycin, the outcome of treatment goes from 75% success to less than 23%. Okay, so this gene mutation, it's particularly important, and when you see a Mycobacterium abscessus isolate, the first thing you look at is the macrolide susceptibility. If it's susceptible, your chance of cure is really high. If it's resistant, then this means that you cannot, most likely you're gonna deal with that treatment failure and all that. With the Mycobacterium abscessus and Bolettii, they have this inducible macrolide resistant gene. That's why you do not see the susceptibility result of Mycobacterium abscessus released before 14 days, because the isolate with the phenotypically might show some susceptibility at the beginning, but if you incubate the Mycobacterium abscessus with the macrolide, then you see the zone of inhibition or the susceptibility go from like susceptible to resistant. I'm going to explain this in the next slide. But again, there's two forms of resistance. There is acquired resistance, which is called the RRL gene. This can be applied to all of them. And in that, if you have this RRL gene, the sputum culture conversion is less than 17%. This is like extremely bad. But then the inducible macrolide resistant, it's a RM41 gene. And if you have any fellows, this comes in every board exam. The RM41 gene, it's always present in the Bolettii and the Mycobacterium abscessus. And whenever the pathogen is exposed to the macrolide, this will lead to upregulation of the receptors, upregulation of the gene. And then as a result of that, the erythromycin methylation gene enzyme will be released, and then they will deactivate the macrolide. So this is like particularly important. And here I just want to highlight the importance of this for in this graph, the Mycobacterium chelonia, as you can see here. So basically they took isolates from Mycobacterium chelonia and Mycobacterium abscessus group, and then they incubated just to highlight the RM41 gene mutation, because it's really critical for treatment. So at the beginning, day 3, 97.3 of the isolate, there were like 125 isolate of Mycobacterium abscessus. They were all susceptible to macrolide. With time, there was only 37.1 isolate susceptible to macrolide, which that indicates that, do not read them, do not accept any susceptibility to clarithromycin or the macrolide unless the organism was incubated with a test agent for more than 14 days. Okay, so this is like really important message here that we need to talk about. And then here, this is just according to the regimen and the break points according the CLSI breakpoints. As you can see here, the only drug that's been linked to outcome in treatment of an NTM infection is the macrolide. All the others, you see susceptibility in vitro does not necessarily translate into clinical outcome. But here you can see here the clarithromycin, anything above 8 is considered resistant. Also here, it differs from pathogen to another. In MAC, it's like 32. Also in KSSI, it's 32. And then we have all the other drugs. But again, there's not a single drug here. It may be the amikacin and to some extent the imipidine, but most of these drugs here in mycobacterium abscessus, you see susceptibility results in vitro. It does not really necessarily that the treatment outcome will be good or bad. It just says susceptible, but there's questions that the media that we use sometimes for treatment of this. So anyhow, this is according to the ATS guidelines for treatment of mycobacterium abscessus. And again, it's further divided based whether there is mutational resistant, inducible resistant, or susceptible. And this is the thing that we discussed in the previous slide. But basically, if you are treating mutational resistant due to treating mycobacterium abscessus with mutational resistant, you see that you need more than like 6 drugs sometimes in the initial phase, and then you go in the continuation phase with like 3 drugs. So this is different drug regimens here. Of course, you cannot use that azithromycin if it's like inducible resistant or there is mutational resistant, but when it's susceptible, you probably can get away with 2 to 4 medications in the initial phase, and then you go to the continuation phase with that. So your best luck is to have a susceptible mycobacterium abscessus that is Mycobacterium mellicens subspecies. But if you have Bulleti or abscessus, this is just a true nightmare. Okay, this is available online. This is just summary of the ATS recently published guidelines. Again, there's so many medication, and also we have the omadacycline, which is not included here, but the mycobacterium abscessus isolate are uniformly susceptible to omadacycline. They're always susceptible to omadacycline. Does that mean there's a clinical outcome or no? I really don't know, but we'll get to that later on. So this is the classical report that you'll see, and it's like true antibiotic nightmare. Look at this mycobacterium abscessus. There's like it's almost resistant to everything. The tigecycline there's like the MIC is equal to 0.25, but there's no breakpoint, so you can't tell what's going to happen. And most of the time, people don't tolerate that. The clofazimine, a lot of us like have really difficult time obtaining the clofazimine here in the United States. And then the amikacin with the toxicity, with the acute kidney injury and all the toxicity, people usually do not tolerate. So what do you do in a situation like this? So this paper here in AC, they compared the treatment outcome of mycobacterium abscessus to MDR tuberculosis. They called it worse and similar to XDR tuberculosis. And that's actually true, right? You don't have medications, you don't know what's going on. I mean, you start patient on multi-drug regimen, the outcome is worse. The XDR tuberculosis, the outcome, it's shown in some papers in the 50s, but this here, it's reported less than 23%, which is ridiculously bad. I mean, this is a true nightmare when for us, like ID physician, to see a report of mycobacterium abscessus like this. It's just really bad. So here, there's another paper that was published in 2012, and they describe mycobacterium abscessus as a new antibiotic nightmare, and treatment failure is severely bad. We do not have medications and all that. So here I'm going to move to the second part of my presentation, which is the research that we are doing, and I'm going to just focus on this idea on how we took an idea from the lab to the bedside, the bench. Okay, it's a work in progress, but there was a lot of work that's been done. There's 3 or 4 labs who were working on the same idea at the same time, but I just want to tell you guys, take you through a story on like how we started, what we've been through, and where we're at now. Okay, so again, the reason why most of the beta-lactams were not utilized to treat mycobacterial infection in general is because the mycobacteria produces a beta-lactamase. Okay, and this beta-lactamase is able to hydrolyze most of the penicillins and the cephalosporins used. Okay, so the traditional beta-lactamase inhibitor that we have, the clavulanic acid, the tazobactam and sulbactam, the investigators in 2013 tried to inhibit the beta-lactamase of Mycobacterium abscessus using these beta-lactamase inhibitors without success. Okay, so then the story was closed. Like, we cannot inhibit this beta-lactamase. This means that we are unable to use any beta-lactams because the M. abscessus produces beta-lactamase. So we cannot use beta-lactams, and then they close this page. And this guy here just mentioned the major molecular factor limiting effectiveness of beta-lactams against Mycobacterium abscessus is BLAMA. Okay, so I'm going to refer to the beta-lactamase of abscessus as BLAMA. Here, this is a nitrocephin test that we use in the lab. It's straightforward. I mean, don't get intimidated by the tubes here, but this is the nitrocephin test, which is basically a beta-lactam. When you put the Mycobacterium abscessus with the beta-lactam, the color will change, which indicates that the nitrocephin was hydrolyzed. So the color changed, okay? Then what the investigation did in this study, they knocked out the gene for BLAMAP and they incubated the nitrocephin abscessus, and there was no change in color, which means that this antibiotic, the nitrocephin, was hydrolyzed. So there was like a direct proof that the Mycobacterium abscessus produces the beta-lactamase and it hydrolyzes the nitrocephin. So, okay, we have something here, okay? So the traditional beta-lactamase inhibitors that they were used, they could not inhibit the BLAMAP. Then, of course, you guys know this already. In XDR tuberculosis, we use meropenem, amoxicillin, clavulanic acid as a salvage therapy. So what's the story behind this? Again, Mycobacterium tuberculosis produces beta-lactamase, but the difference is that the beta-lactamase of Mycobacterium TB is susceptible to inhibition by clavulanic acid. So you give amoxicillin clavulanic acid with miro, and the clavulanic acid will protect the meropenem from the hydrolysis by the beta-lactamase of MTB. So this is not a new idea. This is from the New England Journal of Medicine. So basically, this was the hypothesis here is if you can inhibit the beta-lactamase of MTB, then you can use beta-lactam. So they were able and successful to inhibit the beta-lactamase of MTB by clavulanic acid. So but in M. abscessus, this was not the case. Okay, then here, this group here, basically, they also worked on the beta-lactam and beta-lactamase in Mycobacterium abscessus. And then, as you can see here, the amoxicillin, when they knocked out the BLAMAP gene, the beta-lactamase gene, the MICs went from 256 to 214. Which is kind of really impressive. So if we have a beta-lactamase that can suppress or deactivate the BLAMAP, then we are good. So this was the hypothesis, okay? And then this group again, if in the absence of of beta-lactamase in M. abscessus, when they knock it out, the MICs of amoxicillin was as effective as imipenem. So this brought up this idea, like you can see here. I don't think anything is mentioned here, but most of the beta-lactamase here, like they mentioned, the ciprofloxacin, the ceftriaxone, the ceftazidime, all the MICs were really high. The imipenem, for some reason, it's resistant to hydrolysis by BLAMAP to some extent, but also there's some like hydrolysis, meropenem, same thing, ertapenem, norepinem, and aztreonam. So because of this BLAMAP, these beta-lactams were not able to be utilized, and when they knock out the BLAMAP gene, then you can get better MIC. So can we focus on this BLAMAP? All right. So this again busy slide, but again I just want to I will try to simplify as much as possible. So we talked about the BLAMAP, okay? So the BLAMAP will hydrolyze the beta-lactams, okay? And then we have the two groups of enzyme that catalyzes or do the cell wall elongation. This is the layer that I earlier presented in my presentation, the peptide glycan layer. So that's basically it. So two adjacent peptides, okay? This enzyme will catalyze this cross-linked and connect them. So it's like a beads that's getting connected by these two groups of enzyme, the LDT transpeptidases and the DD transpeptidases. So there's two groups of enzyme. This enzyme is more important in mycobacteria, and it does like 70% of the work. So it will link the third amino acid and the third amino acid in two adjacent peptide, okay? And then this is how cell wall elongation happens, okay? And this is a DD transpeptidase and does 30%. So these are two groups of enzyme. So they catalyze and they elongate the cell wall. The hypothesis is if I can have a BLAMAP inhibitor, so I can use the carbapenem or cephalosporin or penicillin to deactivate these enzymes. Very simple, straightforward, okay? I need to inhibit this enzyme, and then I will get these enzymes like I need to inhibit this BLAMAP, the beta lactamase. I will have these penicillins work on the cell wall and inhibit this the catalysis of the elongation of the cell wall. Very simple. Okay, this is how we started thinking. Then became the group of DBOs, right? The DBOs, the avibactam, rilibactam, there's new inhibitors. So this is when I joined the business, okay? The avibactam was first introduced at that time, and it was tested against the BLAMAP. And as you can see here, when the avibactam was added, for example, here in the cefuroxime, the MIC went from 256 to 32. Same thing here. When this is a different medias, and this is the deleted BLAMAP, but just focus on this one here. So the MICs were 256. When they added the avibactam, went to 8. So this was like amazing. So they studied in this group, they described avibactam as the first efficient inhibitor of BLAMAP. So we got like really excited, okay? And then here also, this is just a zebrafish. I just don't focus on this, is like too much noise here, but this is the zebrafish basically, and you can see here the infection was here, and then when avibactam was added, because there was a question whether the beta lactams can get inside the cell or no, and I earlier discussed this like lipid bilayer that covers the mycobacteria, but generally speaking here, the avibactam was able to get inside the zebrafish and eliminate the mycobacterial abscesses. And then when the zebrafish was not treated with the avibactam, there was like worsening of infection and all that. So this is just so again, coming back to the same slide, we can inhibit the BLAMAP with the avibactam, and then we protect the penicillin, cephalosporin, and carbapenem from the hydrolysis of the BLAMAP. Okay, straightforward. And then, so this is when I started the work. This was my first poster. So we added the avibactam to ceftaroline, and the MICs went from 16 range to less than 4 in 31 of the 35 cases isolated. Okay, so the ceftaroline for some reason was found to be resistant to some extent to the hydrolysis by the BLAMAP. So that's how it was started. And then I was like, okay, so we have something here. This is one agent that we can use. But the problem is avibactam is paired with ceftazidime. Fortunately, when we add this avibactam to ceftazidime, it didn't add like much killing, but that was kind of interesting to see this improve or enhancing the susceptibility of mycobacterial abscesses to ceftaroline by adding avibactam. And then these are the DBOs that we talked about. So the first worked on the avibactam, then the rilibactam came, and the rilibactam is paired with imipenem. It's available now, FDA approved and all that, okay? So my first project was on the rilibactam, and then I later worked on the darolurbactam, which is now also FDA approved and available paired with sulbactam for treatment of multidrug resistant Acinetobacter baumannii. Okay, so we have new inhibitors. These are the DBOs that I worked on in the lab. Okay, so here, this is the paper that we worked on first. Okay, I was very disappointed when I tried the rilibactam. So the rilibactam, when we added to the ceftaroline, the MICs went only one dilution, so not a very good inhibitor. And when I added the rilibactam to imipenem, there was no change in the MICs at all. And then I asked myself, what are we dealing with here? I know rilibactam is not a good inhibitor, but why we're not seeing any change in the MICs? Is the imipenem actually hydrolyzed by BLAMAP or the beta lactamase or no? So this was a question. And also, we know that the avibactam is a very potent inhibitor of the BLAMAP, but again, the MICs of rilibactam of the imipenem didn't change, unlike for ceftaroline when the avibactam was added. This is the area study or experiment that we did, but basically when avibactam was added, the MICs went down, but why didn't go down with imipenem? So we kind of stuck. But then during a moment of serendipity, it was like pure luck. I was with this guy, Sebastian Kurtz. I think if you three here, he knows this guy. So we were playing with the MICs. So basically what we did, we measured the MIC. So this is microblot dilution, guys. This is the test we sometimes do. And basically, you know, you measure the MICs and you see was there is no growth, you read the MIC here. So what we did is that we tested the imipenem alone. This is something we already did. And then it was Sebastian's idea. Well, I'm not gonna like claim it, but I was like, why don't you just add ceftaroline, a fixed concentration, and see how it happens? What happens? So the MICs went like really significantly down. So it was like, okay, do we really need to inhibit the BLAMA? Maybe we can just do 2 beta-lactams, and we'll see how the MIC would go. I was like, and what's the hypothesis? So we started to try to understand. While we are working on this project, and before we publish our paper, this guy Gaino, he works at Johns Hopkins. He kind of did some testing and came up with this doropinam and cefdinir exhibits synergy against both pan-susceptible Mycobacterium abscessus. And then you can see here the MICs for doropinam and cefdinir, which doropinam is a penem. I don't think it's approved. Maybe. Here in the United States, but basically the MICs were really low in some isolates. So like, what is that? I mean, so this was published before, like we published our data. So we were kind of late. And then later on this group, this is my mentor here, but I wasn't a part of this work. The ceftazidime, when added to ceftaroline, the MICs went to 0.25. The MIC for ceftaroline was 32. For ceftazidime with avibactam was 512. But just by adding 10 microgram of ceftazidime, the MIC went like to 0.25. This is the control setting of Mycobacterium abscessus. And they also did this time kill assays and basically showed that, you know, when you combine the ceftazidime with ceftaroline at a concentration of 100 for the ceftazidime, the MIC went like the log phase was like really down compared to no drug or compared to the drug in different concentrations. So this was direct, the second paper that came to address this concept like of dual beta-lactam. So in the next few slides, I'm gonna show you guys like what is the concept behind using dual beta-lactams in treatment of Mycobacterium abscessus and other non-tuberculous mycobacteria. This is the paper that I think we talked about a lot during our discussions in the group. But basically here in yellow, these are the MICs of ceftaroline. In blue, these are the imipenem MICs. But when you combine the imipenem and ceftaroline, the MICs will go really low. And also, like when you add the relibactam, this doesn't add any benefit. So we know already that the relibactam, I don't want to like spend too much time on the relibactam because it's not a really good inhibitor of the beta-lactamase of M. abscessus, but this is something we can think of. So this paper was published after a lot of like headache and pushback. Also, we wrote this commentary in the CID about this synergy and how great it is. So just speaking about, this is not applied only to the Mycobacterium abscessus. All the other non-tuberculous mycobacteria, they have LDT transpeptidase layer. Remember that layer that catalyzes 70% of the cell wall elongation. All these being characterized, and we have different group of enzymes. They call LDT MAP, LDT MTB, LDT Africanum, something like that. So they are named after a species. So this LDT transpeptidase, this important group of enzyme, is present in most of the non-tuberculous mycobacteria. Okay, so then here, this slide that I really like a lot. So I'm going to spend like some time here. So basically, our hypothesis was this is the BLAMAP we talked about. So if you can inhibit it with some kind of beta-lactamase inhibitor, whether avibactam and relibactam, okay, and then protect the imipenem and ceftaroline so they can do their work. So do you introduce this concept of target redundancy? This is a group of enzyme, the LDT transpeptidases. They're called LDT 1, 2, 3, 4, 5, something like that, okay? So if we can add the LDT add the do beta-lactams so they can target multiple like cell wall synthesis. And we have done this before. All of you guys have used beta-lactams before. In Enterococcus faecalis endocarditis, we use ampicillin and ceftriaxone. The ceftriaxone targets the penicillin binding proteins, 2 and 3, and the ampicillin will target ampicillin binding proteins 4 and 5. So this is another new concept. You've used dual beta lactams before in Enterococcus faecalis, and it reserved the use of aminoglycoside in this situation. So none of you guys haven't like used this concept. So it's not a crazy idea. So just adding to protection from BLAMAP, and for some reason these DBOs was found to have some intrinsic activity by their own. I don't know what the significance of that, but avibactam and relebactam were found to have some in vitro activity against. So if you do the MICs for avibactam, relebactam on their own, they will have effect, and the MICs will like be to some extent lower. So we published this, we introduced this target redundancy, which these group of enzymes are redundant, and they when one get deactivated, the other one will take over. When one get deactivated, the other one will take over. But you probably guys can see that LDT map to nothing bound to it. This was like mass spectrometry. So we basically incubate the drug and the protein together, and then we run them in the mass spec, and you see a peak. When you see this peak, this is the sum of the protein and the antibiotic, and then you say that there is acyl enzyme complex formation, which means that the antibiotic is hitting the target. So this is after the mass spectrometry data. Okay, and then this is the LDT map2, which is thought to be the most critical enzyme among these LDTs that we talked about. All right, I will skip that. It's kind of like too much. All right, so what about the darolubactam? I earlier mentioned this darolubactam. Again, the concept is simple. The darolubactam will inhibit the BLAMAP, the imipenem, and amoxicillin will target the LDTs. Same concept, okay? And then here, we showed that the MICs, for example, of amoxicillin alone here, when you add amoxicillin, darolubactam, the MICs goes really down to 1 and 4, okay? Then here, the MICs went to less than 0.12 when imipenem, darolubactam, amoxicillin paired. So again, the concept, this is by far the most and strongest inhibitor of BLAMAP of mycobacterial abscesses. It is really strong. This drug is like amazing. I mean, this beta lactamase inhibitor, although it's used broad spectrum beta lactamase inhibitor in Acinetobacter baumannii, but it is extremely powerful, has its own intrinsic activity, and by the darolubactam by itself, MICs were similar to imipenem. So I don't know, this molecule is just fascinating and I love it so much. But generally, it's this it will suppress the BLAMAP and protect the imipenem and amoxicillin here. All right. So this paper is still under review in MBio, but we're going into a second round of review. Unfortunately, this week, I don't know why the author maybe didn't like it, but generally speaking, it's available in the bioarchive. But with the salopinum is another oral carbapenem. It's I think utilized in Southeast Asia, especially in Japan. We combined the ciprofloxacin with salopinum, and we got really lower MICs, and the same concept again, target redundancy and all that. So what about some clinical cases? This is the last part of my presentation here. This Chuck Daly here in the ID week of 2022. Basically, there is this patient who was started on this regimen here, and then was like not doing okay. The cavity was like really large, and then the ceftaroline was added here, and you said, boom, cavity collapsed and all that. And after this actually case, we were like bombarded with so many questions in the lab, people asking for like susceptibility testing and all that. So so far, by far in the United States here, I've done testing to more than 200 clinical isolates. So the clinicians, they reach out when they have difficult to treat non-tuberculous mycobacteria, and they send it for us for synergy testing. We've been doing this for like 6 to 7 years. And this is the Chuck Daly group from the National Jewish. They published this treatment of mycobacterial abscesses pulmonary disease, and they included the imipenem and ceftaroline as a salvage therapy based on our investigation. And also this is the ceftazidime from that paper that I discussed with you guys earlier, okay? And this is what we see here. For example, like in the microbroth dilution, you see the MICs here. You add 1 microgram of ceftaroline. The MIC for imorapinum, for example, goes from here to here. Unbelievable, from just like 1 microgram. Same from ceftaroline here also. And then we also sometimes work on some compounds that has no names, and we kind of try to enhance. And then whenever the folks here in the United States, I mean, if you have a difficult to treat mycobacteria, feel free to send it to us. We can run the susceptibility testing. We report something like this, and it usually takes like 1 week to do. This is another case that I worked with Bayan and the people at the Mount Sinai Hospital. This was a difficult to treat mycobacterium abscessus that has the RRL gene. So basically, this patient was treated with imipenem ceftaroline combination as a part of multi-drug regimen. The MICs went down, the patient achieved cultural conversion. The success rate for this case, according to literature, was 17%. But I believe that the dual beta-lactam here helped a lot and helped with the culture conversion. This is another case that was just treated with imipenem and amoxicillin alone. There was a multi-drug regimen, but at some point, patient was only on imipenem and amoxicillin and achieved sputum culture conversion. This was also one case that we published. This is one disastrous case. Patient went traveled to the South America area for medical tourism and came back with like meningitis by mycobacterium abscessus. This was the regimen that was used. They used ceftaroline and imipenem as a part of multi-drug regimen, and this is the recommendation. They did not include me in that paper, so I feel bad. So we are working now on this on dual beta-lactam approach for treatment of mycobacterium abscessus in adults. There was like 19 patients. This group there in Florida, they worked on this regimen, different regimen they used, and they were like very sick patient transplants, but the treatment outcome was actually better compared to the standard of care, and use the dual beta-lactam combinations in this table here, and there was tendency for cure among patients who were started on the dual beta-lactam early compared to those who died and also start treatment. So they had a positive signal. I'm still working on this paper. It's unpublished yet, but this is another case that I worked with my our MVP Zahir, and they reach out to me about that case. She was, I think, pregnant. She had skin and soft tissue infection and anterior abdominal wall by mycobacterium abscessus. We do not have susceptibility, and we did not do the testing. But again, in this case, they initially treated with Dr. Zahra and Sarah. I don't know if she was taking care of the patient or no, but they used ceftaroline and imipenem initially based on like the conversation we had, and then followed by oral amoxicillin and ceftonir, and this was accepted as an oral presentation in ECMID. So if you are guys going to ECMID, make sure you attend this poster session or like oral presentation, it's oral presentation session, and then support the team from United Arab Emirates. And then finally, this case is still also under review. This is a child who was really sick. I think as Dean and other people who are like in the peds world, the team reached out to us. So like extremely difficult to treat multi-drug resistant mycobacterium abscessus that is so hard. There was no medications, and in pediatrics and women's, it's so complicated because you cannot use so many medications that on the list. I mean, you cannot put a pregnant woman on like amikacin and like clofazimine or bedaquiline, all these drugs. So these are a group of patients are particularly at risk. So this paper is under review now, but beta-lactams are safe in pregnancy and also safe in childhood, and they're actually the best. And I believe that we are not using the right medications for these NTMs. So this kid was treated with imirapenem and ceftaroline as a part of multi-drug regimen, and then was stepped down to ceftonir and imipenem after that, and then the patient achieved microbiological and clinical cure using this. And interestingly, go back to Zahir and Sarah case here. This patient was only on dual beta-lactam, by the way, did not get a multi-drug regimen. She was pregnant, and this was like something really disastrous. Anyhow, this is also another approach. I think I don't remember who we talked. I was like talking to Mustafa, and there was I don't remember if while somebody else from the group, we were talking about the concept of like just putting antibiotic in because this is how desperate people are now. You put the antibiotic powder in the skin soft tissue infection. This is actually Cesar Arias reviewed this paper, and then there's a group of investigator who used topical antibiotic to treat skin and soft tissue infection, which is kind of interesting. Anyhow, I think I reached perfect timing. I reached the end of my presentation here. Again, we talked about the culture media and condition, and then when optimum in vitro media to predict antibiotic efficacy in vivo. It's unknown. I don't trust all these culture data that we have for NTM, and I don't think we're using the right media. So this is an area of research. And for folks here in the United States, Robert Beno always tell me, if you are unable to defeat it, we would like to meet it. So if you have any difficulty to treat NTM, you can always reach out. We can figure out a way how to get the isolate and get the isolate transferred here. Here, the Mycobacterium abscessus treatment with or without beta-lactamase inhibitor. Again, we use the dual beta-lactam with success, but I'm not saying that you can ignore the beta-lactamase. I don't know if you can ignore it or no, but this is like also an area of research still, but we're working on it. But if you treat abscesses, you can use imipenem plus cefuroxime, cefdinir, or ceftaroline. The isolate will most likely be susceptible if you don't have capability of testing. This should be like a salvage therapy. If the organism is macrolide resistant, the guidelines will leave you with no clue on what to do. So definitely you can just simply proceed with empiric dual beta-lactam coverage, and then later on figure out a way to test for susceptibility and all that. And then the imipenem plus ceftazidime avibactam. Again, the imipenem and ceftazidime are synergistic, and the avibactam will suppress the BLAMAP. The imipenem and relibactam plus amoxicillin. This was a really good paper in Nature. I didn't show it, but basically show the imipenem, relibactam will have some protection for the amoxicillin, and the MICs are just wonderful. In MAC, the story is different. The MAC does not have beta-lactamase, so you do not need a beta-lactamase inhibitor. So you're treating multi-drug resistant MAC, you can try the beta-lactam, meropenem, cefuroxime. Actually, we have a paper under review now at JAK-AMR, general antimicrobial resistant. It's called JAK-AMR, but it's also still under review, and meropenem and amoxicillin, that's in vitro data. Again, this is all applied when the macrolide is resistant, or if the patient is not able to get the first line therapy. We'll be working with the NIH, trying to figure out if we can go into phase 2 or 3 clinical trial with adaptive superiority, which basically we do standard of care plus do a beta-lactam, or standard of care alone, and try to see which one is better, or if there's any benefit of adding 2 beta-lactams to the standard of care. And this is kind of something we're working on. I have a presentation at the Gordon Research Conference in March. So that's basically what I've done. This is by far here acknowledgement. I would like to thank you all for listening to this really long talk on the weekend. But these are people who made me who I am. All their names here, and I'll take questions. I think I talked too much, which I don't like. Yeah, thank you.
Thank you, Khalid, for the fascinating, remarkable talk. I think we all learned a lot today, and I'll open the floor for any questions.
Can I start, Hamad from Doha? Thank you, Khalid, for the very informative, fascinating talk here. This will sort of throw a lot of questions. As you know, Mycobacterium abscess is a nightmare, as you mentioned, and any one of us who had cases struggle with treatment. And, my question regarding the beta-lactamases, so most likely this is like molecule specific, the same like in Enterococcus, when docking into the protein binding protein, and the difference between ampicillin and ketonosporin. So the first question about, carbapenems, you use an American mepenem, we don't have it in here. And most likely there is a difference in the molecule between imipenem, meropenem, and ertapenem. Can you extrapolate the sort of the result for imipenem? For example, we have patient here, we try to treat with meropenem, and is the efficacy of meropenem is as comparable to imipenem?
Yes. Go ahead. Sorry.
Yeah, you can answer that if you want, and then
Yeah. So the thing is, if you look at the MICs from meropenem, they are slightly like better by like worse by one dilution for like M-abscessus isolate most of the time. But that's why the imipenem is included and not the meropenem. But this problem with imipenem is that very has like really short like half-life. It's 2 hours. In 2 hours, you will have no imipenem in your blood. So we ran into this issue when we were like dosing the imipenem. But to answer your question, for the ertapenem, it absolutely has no activity against M. abscessus. The MIC is almost always high. But for the imipenem, perhaps this might be the only approved penem now that has lower MICs compared to other like carbapenems. But you can, yes, and people have used the meropenem for M. abscessus with success.
okay. I also for cephalosporin, I think most likely there is sort of rating. The guideline called cefoxitim and ceftazidime also, we don't have cefoxitim. So the is ceftazidime is the sort of like replacement for cephalosporin?
Yes, they are absolutely right. So the ceftazidime is a replacement, but I just want to show you something here. Let me, can you see the slide?
Yeah, I can. Yeah.
Yeah. So let me just go back to the paper. So here, this paper here, when the ceftazidime was added to ceftaroline, the MICs went really low. You can probably see that here. And the imipenem with ceftazidime, when it added a 10 microgram, the MICs went for imipenem from 8 to 0.25. Same thing when it was 50 concentration, and when it was 100, the MICs were significantly low. I don't know if you can achieve or extrapolate from this MICs in vitro, but generally speaking, you need 10 microgram of ceftazidime to drop the MICs to 2. You need 50 to drop the MIC to 0.45. You need 100 to drop it to 0.25. So this is something that you definitely can try. Imipenem with ceftazidime with or without avibactam.
Okay. My last question is a contentious question. You're talking about dual therapy. Why not triple therapy, for example? Because as you saw scientifically, the more you inhibit this beta lactamases, the more efficacious it will be. Do you think that will be a line in the future?
I am very impressed with this question actually. So we just had one person in our lab just tried this triple treatment, and the killing was 100% in time kill, 100%. This and compared, they did a time kill study when they did 3 beta-lactams, when I'm saying three, there can be like 2 beta-lactams, 3 beta-lactams with or without beta-lactamase inhibitor. The more you add and you compare it to the standard of care, which is the 3 drugs that we use, this does nothing. And the multiple beta-lactams, when they are used, the killing was 100% in time kill. Complete eradication.
Thank you. Yes, that's
Yeah,
very
thank you.
impressive.
Very impressive question. Thank you. Thank you. Neda.
Yeah, Khalid, I just wanted to congratulate you. This is amazing work and really meaningful work. Yani. All the patients of M. abscessus I've seen in my life have been the most difficult to treat. And I still remember this patient from my fellowship who went to Mexico for tourism as well, medical tourism, and then came back with uh, buttocks implants that got infected, and she was going to surgery one day after the other. And unfortunately, just did not do well afterwards. So this is really important and impactful. My question is that how far are we from clinical translation at this point? I know you mentioned something about another group that is looking at clinical translation of this, but how far are we from that?
Yeah, so Neda, you probably know about this regulatory, and thank you for your nice words. But the issue here is that first of all, like this NTM word is kind of like really hard to run a clinical trials in because part of it is to not able to getting the sample size needed, but also like there's also group of people that need to see some clinical data before. That's why we're working on the case reports. Now working on case report, case series. Whenever we build up some like cohort of patients, we can, we were talking to the NIH whether we can move directly to phase 2 or phase 3 clinical trial versus, or do we have to go through animal phase? Because the animal phase will take so long, and the animal phase the animal world is so complicated because for some reason the mice clears the M. abscessus regardless. Like, you infect the mice with M. abscessus, next day it's gone. It doesn't cause disease in mice, and it's been like really big trouble. A lot of people that have tried to go through the animal phase and in the mice phase, especially for like before the clinical trial, and that was not very successful. But I think what's most likely going to happen, there are going to be like more case report and case series of like treatment success, and then they will move straight to either phase 2 or phase 3 clinical trial. But this will need a lot of like arrangement, and I don't know if this is happening. But until then, I mean, now the guidelines leave you with like absolutely no guidance when there's macrolide resistance. So I think having the dual beta-lactam is like really safe approach. We've tried it before, and it might be just something you can at least do until we have new drugs, or maybe we completely switch to triple like beta-lactam for NTM infections, and then just abandon the current treatment guidelines or regimens. But this been like, thank you for the question. I mean, we've been in communication with the NIH to answer your question short, and then we'll try to figure out if we can move to clinical trial or no. But this will need like training grant, which should take 2 years. And after that, you start the clinical trial, or patient enrollment might take years. But I can tell you that there's a lot of physicians now that use dual beta-lactam with or without beta-lactamase inhibitor, because basically there's no other drugs. So.
Is there a network of NTM clinics or providers in the country?
Yes, it's
Similar
actually
to like, okay,
yeah,
good.
yeah.
Very good.
They have this network. It's basically Kevin Winthrop and Chuck Daly. They are running this consortium.
There is question from Mustafa.
Yes, Mustafa. I know you read my paper.
Thank you, Khalid. Really wonderful work. أنا صراحة I'm one of the most pessimistic people around NTM infections, and I usually tend to avoid them. And I literally see no hope in trying to eradicate the NTMs microbiologically. And I always just ask the question, what's a primary problem? So usually most of them have like a primary problem, either immune suppression or structural lung disease, whatever. And I just really talk around fixing the primary issue rather than trying to treat the NTMs. That being said, I'm very optimistic about the things you are doing. At least show that there could be some hope, even if not now, but maybe definitely in the future. And now my question to you is about, I can see that, or my understanding is that seems like a concentration-dependent killing, drug concentration-dependent killing. And how would that be translated, clinically when giving? Are we going to use different doses? Do we need like drug levels monitoring to ensure that, we're not wasting this chance in vain? Do you think that's something we should be mindful of whenever we use this regimen?
Thank you so much. This is a really good question. So thank you. Yes. So there's some. I told you about like the imapinum. That the imapinum is usually cleared from the body. The half-life is in 2 hours. There will be undetectable levels of imapinum. So that's been like really an issue. So the problem is that some of these drugs are like so you need a concentration. Well, I mean, you cannot take the same numbers because in the body, like in our body, these things does not work similarly like the in vitro, right? But I agree with you. Yes, there is a need for each certain drug to be in certain level for this synergy to be seen. Yes, to answer your question. And then sometimes especially when people like getting treated at University of Florida here, we have research labs that they can measure drug level, and we say yes, please go ahead and measure it, because that will give us like really insight of like the pharmacokinetic, pharmacodynamics, and all that. But when I worked on some mice before, and I killed 20 of them. I still feel bad about it. But you give the imapinum after 2 hours, the imapinum is gone. I don't know what happens in humans' body, but we took a group of mice, we gave them imapinum. 2 hours, you kill them, you take your blood, you find that there's no undetectable level. I know the mice that clear the imapinum faster than humans, but again, that brings us to Dr. Hamid's question whether we need a more stable carbapenem, like meropenem, if you can use it. Why not? Why do we have to stick to imapinum because of this short half-life? But you have to answer your question, Mustafa. Yes, absolutely, we need to measure the level.
A follow on, yeah, Khalid.
Mm.
Do you think if I'm trying like a dual beta lactam combination, then if I do not see like what I was hoping to see like in terms of clinical response, do you think would it be like a good idea to try higher doses? Like maybe?
Yes. So the problem is when you go with the ceftaroline, in my experience, that's why I recommend doing it like twice daily, because when it's done 3 times daily, you run into the problems, cytopenias, hepatitis. It's just a nightmare. I mean, ceftaroline is a great drug. I love it, but the neutropenia happens on almost like 20% of patients on ceftaroline, and especially if you're planning. So what we usually do is like 2 weeks of IV, sorry, 2 months of IV at the beginning. So you push as much as patient can tolerate, and then that way you can like break the cell wall, fracture it, there's also this hypothesis that if you can fracture the cell wall, the other drugs will get in. This is just all like concept that we know in ID that's never been proven before, but you can try use them. But like if you go with the higher doses, you will run in side effects. I'm like really sure about this.
And
But
a last one, sorry. Have you tried continuous infusions? Because beta lactams usually time
that
above MIC. So
advice,
maybe if you
yeah,
run, yeah, have you tried
yeah.
that?
Well, I mean, I know this area, the PharmDs were very happy about this continuous infusion, but I've never tried it. And the problem is most of these patients are outpatients, so it's so hard to put a patient on IV infusion for like it's just draining. But I think that would be ideal.
There's a question
Thank
from
you very
Tahir
much,
and
Khalid.
then Ahmed Abu Bakr.
Yeah. Go ahead,
I think Ahmed's hand was raised before me, so Ahmed, go ahead, please.
Ahmed, go ahead.
Thank you, Zaid. Thank you, Khalid. Excellent presentation. Really, I love it and I like it. I mean, this is one of the bug that is, if there is any area in infectious disease, really, I didn't like this NTM. It is just really a nightmare. Excellent work, and hopefully we see something out of this. I mean, this combination in the future.
Yeah.
I don't have a specific question, but I have bad news for you.
Mm.
When you talk about mycobacterial smegmatis, you said it is really low. Last year, I have a case of aortic valve endocarditis after surgery. As patient had aortic valve, aortic stenosis, and then he had aortic valve and root.
From smegmatis?
And he developed smegmatis.
Interesting.
Yeah, and it's just it was a nightmare to me. It was, and I don't know how you can and why it is not like the TEE was negative. The initial CT beta scan was negative. We treat the patient, relapse again, and then we treat him again, and then relapse. And all TE that we have done is negative. At the end, we have to stop the treatment for maybe 1 month. We let him go and with positive culture. And then we did the CT beta scan. It proved that there is infection around the aortic valve and root, and he had to have surgery. And then after that, he just cured. So this is just a nightmare, I think. Whenever
I
I
agree with
think
you.
about it, it is just
I agree with you. I mean, Mycobacterium smegmatis is the kind of control mycobacteria in the lab, believe it or not. I mean, this is what we found in the paper, but I'm very interested to hear what you said. I mean, This is what this group published. Basically, they put stigmatis anterior as like almost always not pathogenic or not causing disease. But Mycobacterium gordoni, I've seen a case of skin surgical site infection by gordoni too, but although it's very low. So yeah, I mean, there's a lot, and this was in 2018. You don't know what happened like since then. I mean,
Yeah.
there's a lot of these bacteria, they evolve with this climate change and all that. So
Yep.
yeah,
It's a nightmare.
yeah.
Thank you, Khalid. Thank you. Excellent.
Yeah, thank you, my friend. Ahmed and I trained in Doha together, so we go back to.
Go ahead, Zahir.
Thank you, Khalid, for the excellent presentation. And also thank you for your assistance with managing that difficult to treat patient with very complex background. My question to you is, does one size fit all? In other words, we've got various clinical syndromes for Mycobacterium abscesses, respiratory, skin and soft tissue infection, etc. And my question is about the optimal duration. I know it's not been well defined, but I think skin and soft tissue infections lend themselves to source control in a better way compared to, let's say, respiratory or CNS or other complications. What are your thoughts on the optimal duration, and will you be looking into this if you've got the chance of running a clinical trial?
Yeah, well, yeah, thank you so much for this question, and I'm glad that you're here. So, I mean, the guidelines for like pulmonary infection is like really weird. So the recommendation is like from the culture conversion, you continue treatment for 1 year, and all the time this is like really difficult. So our idea with adding the dual beta-lactam is if we can shorten this treatment duration by just adding 2 double beta-lactam, maybe we can expedite microbiological cure and all that. I mean, you guys saw in the cases that I presented at the end, most of the treatment was discontinued less than 1 year. Then that's mostly, I believe, because the beta-lactam was added to the treatment. And interestingly, a lot of these patients didn't ever relapse or anything after that. So, I mean, what we do is that our idea of this just to do dual beta-lactam at the beginning for at least 2 months with the hope that we can find some oral combination like what you did, Zahir, nicely with your case. We step down to 2 beta-lactams by mouth and we continue throughout the treatment duration. And sometimes for some reason, I mean, I've heard from so many physicians and including Chuck Daly when he was in the ID week, he said, I've seen miracles with this dual beta-lactam. I don't know how it works, but our success was more when treating skin and soft tissue infection comparing to pulmonary infection. We're treating skin and soft tissue infection using dual beta-lactam for some reason. I don't know if this is related to volume of distribution of these drugs into the skin and soft tissue or related to the area environment in the lung. Maybe it's resistant to antibiotic penetration or something, but the dual beta-lactam when used for skin and soft tissue infection, the treatment outcome was like much better. And for skin and soft tissue infection, you wait 3 to 6 months. 2 months of that with like dual beta-lactam. If you can continue with 2 oral, that'll be fantastic. But if you're treating pulmonary infection, I don't think less than 6 months is doable. Again, you saw in the slide, I mean, the outcome of treatment is worse than the XDR tuberculosis, which is something really frustrating.
Certainly, just a follow-up question to that, if you don't mind. So I think, I mean, I quite like the concept of using dual beta-lactams, mainly because A, you're repurposing some of the commonly used antibiotics, and B, the cost is not really that kind of an issue in most settings. But maybe in my case, who was pregnant, we were not really able to use other drugs because of various concerns. But I think most physicians may find it difficult to resist the urge of adding additional drugs to the mix. And this takes us back to the original assessment you made as to whether sometimes the remedy might be worse than the melody itself. So what are your thoughts?
Yeah, that's Wallahi, Zahir, this is the main problem now because every time some people reach out, they want to like publish the case or like report the case. I go into the case and when you go in depth, you find that the patient is like multi-drug regimen, like so you cannot like, ascertain whether the outcome was actually because of beta-lactam or because of the multi-drug regimen or maybe the all together. So, I mean, this is something that, I don't think we can ever control. That's why I think when mentioned about this adaptive superiority clinical design, whether you do the standard of care alone and standard of care plus, because no one will put patient on only two beta-lactams and watch. In your case, as you said, was different because the woman was pregnant, and this is like exceptional case. But in general, like you see like cavity, abscess, bacteremia. Sometimes it's so hard. I mean, to deviate from the protocol and just use two beta lactams. So that's why I think testing this in a clinical trial setting is ideal. But this has been an issue. I mean, if you look at all the cases that I presented at the end, they were all like on multi-drug regimen. So I can't tell whether this was all beta-lactam work or something else. But like, we have a positive signal, a positive outcome. And even in that cohort of 19 patients, there was still like patients who respond, who didn't respond, but they were like super sick on cancer, immunosuppressant. I thank you. This is like really all valid points. Appreciate it, Darren.
Robert, you can go ahead.
Yeah, thank you all. Thank you, Khalid, for the brilliant talk, and also thank you for helping with the patient. I reach out to you. Actually, this patient is, as we speak, is still on the ward, and people like Zahir will be sorting out in my absence. So thank you. So the question is really following on from what Dr. Zahir has just mentioned, in that obviously you showed that beta lactams, you can give them 3, and they do work brilliantly in the lab. And probably Zahir case is just an example in point that you may not need to add all the others to reduce possible side effects. Now, and the temptation, as again already been discussed at the moment, is that when you do susceptibility testing and you can see some oral options there, the temptation is, because there's really no good clinical data about just beta accept the case reports, there's always going to be addition of other extra drugs if they are sensitive, phenotypically in the lab. So so the ideal, just really, again, this is from experience more than from guidelines, is it using 2 beta lactams plus 1 so that is acceptable in the lab, or and what's your experience about clofazimine susceptibility? Because I know you do not have it in the US, but is it based on the isolates you have in the lab? Do they tend to be susceptible to clofazimine?
Yeah.
Thank you.
So, yeah, thank you, Robert. This is good. So you just made me like want to talk about one thing. So, the guidelines, I mean, we as physicians, we don't like to deviate a lot from the guidelines. So if you guidelines recommend 3 medication, for example, or 4 medication in the initiation phase, so you regard the 2 beta-lactams as one drug. With one drug will enhance the susceptibility of the other. So you use it as one, and then you need to select 2 other medications that are susceptible and less toxic. And then if you're starting on 3 medications, you count the 2 beta-lactams as one drug, and the other two are like added treatment. In Zahir case, the woman was pregnant, it was different case, but in general speaking, like for you, like everything looks like on the paper, okay, you use the drugs based on the susceptibility result, and then you select 2 medications and make sure part of them is double beta lactam, and then always try to reserve the beta lactam. So if the patient develop like side effect, try to, because there's data that showed that the outcome when imipenem or beta-lactam are used is much better when they are not used as a part of multi-drug regimen. And again, I mean, I wish I answered your question, Robert, but I mean, this is like really a true nightmare situation. But yes, adding different agents, this is just to treat our anxiety more than anything. But I really truly believe, based on the time kill data, that 2 beta-lactams or 3 sometimes is much better in times of like killing. And they are all bactericidal and all that. So I didn't bring the data. I wish I have this time kill graph, because they compared in the time kill graph the standard of care that we are currently using to the to do double beta lactam or triple beta lactam alone, and the killing was amazing. It was 100%. So I mean, I know for sure that the current regimen that we use for amapsosis and other, like most of the other NTM, is not the right regimen.
Yeah. So the question about clofazimine, I don't know what's your experience about clofazimine.
Yeah, so most of sorry, yeah. So I did it for the antimicrobial agent and chemotherapy, and there was like paper that the mycobacterium abscessus isolates are uniformly susceptible to clofazimine, to omadacycline, and eravacycline, and to bedaquiline. So they're
Thank
all
you. Very
almost
useful.
acceptable. So if you can, I think this drug, I think the safety profile is better than most of the other drugs. I know you guys can get it easier than we do, because we need an IRB approval and it's a lot of headache. But definitely, whenever you can use the clofazimine, especially if the macrolide is resistant. I mean, you saw the case where maybe let me show you this so quickly. This is the case here. Come on. Yeah, this case here, the clofazimine was actually part of the multi-drug regimen. Here you can see the clofazimine was used. This is August 2020 until like, what is this? This is January 2021. So it was used throughout the treatment period, and it was very well tolerated. And also they added omadacycline at some point. The patient had pulmonary hemoptysis, so they used the liposomal amikacin here. And they used to dissolve it at some point. So they were like, this is that was said. This is classical for like hemoptysis. The physician will freak out, get anxious, and they keep just throwing drugs here and there. And we take a look back at the treatment duration and drugs used. I mean, this is just insane. But here, what we care about here is before the patient achieved the culture conversion, he was in a amikacin, imipenem, ceftaroline to some point here after the susceptibility result came, and clofazimine. And then later, omadacycline was added. So, to answer your question short, Robert, yes, the clofazimine, hemoptysis most likely will be susceptible to clofazimine. And I think if you get a chance to use it, that would save you a lot of toxicity and all that.
Yeah, thank you. Actually, this patient at the moment, we're giving clofazimine because the macrolide is resistant. So we're giving clofazimine, and then ceftaroline together with imipenem.
Yeah.
I think that's the regimen. Yeah.
Very good. All right. Okay.
Thank you, Khalid. We went to almost 1.5 hours now. Thank you all the attendings for coming today. This was very nice and great talk. Thank you, Khalid, again.
Absolutely.